The war started in 1982. I was 6 years old, and this is Kankole village. And I remember well when the war intensified, everybody had to run for his life. And people had also to disperse because rebels came, started shooting, and that's how everybody ended up running away. So we are no longer at home, and we went to jungles in different places. We could hide in swamps during the day, but also during at night. And that was not easy, I remember well, because many people lost their lives, but also children were abandoned, the elderly suffered. Thankfully, my mom, dad, and the grandmother stick with us. It was life and death, but in all, they were able to hide us in the bush. Mom went days 3 to 4, look for food. No utensils, of course no blankets, we were all over. And I remember we were naked. And during that time, it was quite a lot of rain, I remember, and we could stand. It is raining day and night. Mosquitoes. Finally, we had some news that the rebels were no more, and also the existing government was being overtaken all over. So we had to go to other safer places at that time. So at the end of the year, at the war, I was almost 10 years because the war started when I was 6 years in 82. I remember seeing people with wounds. There was no medication. At that time, how many doctors in Uganda I can't tell, but we are very few. And even those who were there, they had no what to use. So after the war, Dr. Ian Clark, a man with his vision, only vision, decides to come and starts working with Kiwoko Hospital. The hospital didn't start as a hospital, it started like a clinic and a tree.
When we first came out, it was post-war area. The war, the sort of latest war in Uganda, had taken place between 1982 and 86. And I visited 87, and then 88 we came out and we stayed here. Most of the houses had been stripped of their roofs and their windows and their doors. And then you also had this thing where there were a lot of unburied skeletons. So there were human bones and skulls piled on the sides of the road. And then on top of that, you had really devastating consequences of HIV. We were staying on the top floor of what had been an old farmhouse, which, it had windows and doors and stuff. And patients would arrive on the veranda, among them mothers who needed to be delivered. But the big issue was, I could deliver a baby okay, but I had no theatre, I had nothing to do, a mother in obstructed labour. And so I ended up having to ferry these ladies in delivery into the hospital in Kampala, which was like a 2.5 journey there, and two and a half hours there and 2.5 hours back at that time. So that was one of the things that precipitated us to start a clinic, which then became a maternity centre and a hospital.
I will never forget the first day that I rolled up the drive of Kiwoko Hospital, 1998, out in this remote setting, and found this magical little bush hospital serving community so brilliantly. I knew as I drove through the drive of the hospital that that was going to be the place where we were going to work. I was on a mission to find where the gaps were, where we could be really helpful, where the greatest amount of need was. And one thing that really struck me when I came to Chiroka was there was enormous need. Everybody in the community, the nurses, people who were working there talking about, help us save our babies. Our babies are dying of natural causes. And so I knew that was a gap that we, hand in hand with all our amazing Ugandan team and partners, could fill.
So we call ourselves a general hospital. And general, it means that we currently target to have the main disciplines, so medicine, surgery, pediatrics, and maternity. But we also not general, we don't just stop at that. We now have our neonatal unit, which has been 20 years plus in evolution to get to where it is.
All those years ago, when I was first spending time at Chiroka, one of the things that really impacted me was nurses and mums talking about the fact that when babies were born slightly yellow, which in the West, means they whack you under a heat lamp, these babies were being born jaundiced, and the only chance that they had to live was nurses would take them outside and hold them in the sunlight, or they would put them in cardboard boxes on the windowsills in the hope that the sunlight would get to them. And in rainy season, almost all of those babies died. And it just struck me so powerfully that the simplest interventions could change and save life. And the NICU unfolded really from there. I remember when I first met Sister Christine, I was truly terrified of her. She is this fabulous, powerful, extraordinarily skilled Ugandan nurse and sister. Her presence commands respect, and she really is the mother of our first neonate ICU and has overviewed so much of the work and also trained so many of the teams that are there now.
Been a long journey. From 1989, we had a functional maternity, but that maternity was a small one, but we didn't have a neonatal unit by then. When I came to Chiwoko, we were nursing babies besides their mothers. Babies who had tetanus, babies with sepsis, babies with birth asphyxia. So that's how we were nursing our babies. Adara came in and they met the medical director and other people, the management, and they thought it was the right place to start the newborn unit at Kiwoko Hospital. So the newborn unit started in 2000, and it was only one baby cot, one incubator. And when we started that neonatal ward, a small room actually, it was a small room, we started by training the nurses. People came to know. They came to know that at Chiwoko there's a newborn care unit, and babies started coming in. When the babies started coming in, we could even admit babies on the counters, the working tables, and there was no space for that, for those babies. So Adara thought it wise to build a better unit for the newborn care, and they did, and that is the unit we have. We moved in that unit, I think 2010, May, around there. We moved in, and the number of the babies continued growing. The number of staff continued growing to meet the demand of these babies. So that's how Adara started building a new unit, and now it is working.
Some people are coming in other districts. Some 2 days back, we received a baby who was referred in from the other side of Entebbe. They came in and they were advised by a certain doctor to come in, like there is good care at low cost. So they came in, and we've been getting other mothers from different districts, Mukono, and you have some babies still from Mulago, they come here for that.
Twasookera wa musawo Charles Kasana n'atugamba olubuto lutuuse okuzaalibwa naye abalongo saategeera nti nina olubuto lw'abalongo nange nakisangidde wano ng'olubuto lunumye nti ninamu abaana babiri bye mbasabiramu bingi kubanga njagala kale basome okusinga basome nabo babeereko abasawo ng'abalala.
So we were incredibly proud of the work we were doing in NICU, and we're seeing more and more babies survive, but we wanted to make sure that they also had the opportunity to thrive and that they were doing well after they were discharged home. So we created a program called Hospital to Home, which really focuses on two parts of care. The hospital part is really about making sure we're providing the best quality care for newborns during their hospital stay. So really focusing on their growth, making sure their parents are receiving really great education so they know how to care for them when they go home, and really focusing on neuroprotective care. So that's care that protects their brains. Then they are transitioned to a brilliant team of volunteer community health workers who follow them up for 6 months after they're discharged home to make sure they continue to survive and thrive.
I'm Namugere Prosi. I'm a VHT of Hospital to Home program, and I work in Chikamlo sub-county, all the villages in Chikamlo sub-county. I really want to work as a VHT because, first of all, people call me Musawe in English. They call me a health worker, a nurse. So I feel like I'm happy when they call me that name. My role is to give health education talks to mothers and checking the babies where any child is discharged. I go and see the mother. So what I think, first of all, these babies were born very small. Though the gestation period was that, it was 40 weeks, but they were very small. And these babies, if they were not in H2H program, maybe they would not survive. But this program of Hospital to Home and then the NICU services they provide, these children, they have survived. And I'm very sure they will survive. First of all, I check on their weight and see whether they are increasing or decreasing. I check on the breathing rate to see whether it is not fast breathing or no breathing. So her breathing rate is 55 breaths per minute, which is normal. It's called the Waswa. It's the fastest tune. Waswa's temperature is 36.6, which is also normal. Then I check on the breastfeeding, whether the babies are breastfeeding well, the attachment, whether the mother holds well the baby when she's breastfeeding. Then I give health education talks whenever I come.
Batusomesanga okulabirira abaana, batusomesanga egyokwatamu omwana ng'akyali bebi n'engeri gy'okumuyisaamu ng'akyali bebi. Buli kimu babitusomesanga, engeri gy'okumwambazaamu byonna babitusomesanga. Twawulira bulungi kubanga era twakomawo nga tuwulira bulungi kubanga era akyekinga abaana baffe nga bali bulungi tebalina buzibu bwonna, nabitubuulira byonna ne bapima nga bali bulungi. Netubabuuza ebibuuzo byonna ne babituddamu ng'abaana baffe balungi tebalina buzibu bwonna.
Yo, yo, yo.
husband is very supportive and very active and surprising enough, he knows how to hold the small babies.
One of the things we've seen over the last quarter of a century is that if you go deep and you stay long, you can begin to see the components of care, the things that really turn the dial. And so a great example of that, for instance, is going from a centre of excellence at Chiroka to hospital to home, that fabulous work, and then all the components of care that make up what we now know as AdaraNewborn. And AdaraNewborn, of course, is now a model of care that is so holistic that it's being adopted throughout the country, and we're taking to scale. It's going to have an impact not only widely in Uganda in the settings that we work in, but more broadly than that, on a global stage, because it truly creates a model of care that works for low resource settings for mums and babies in huge need.
After working with Kiwoko Hospital for all those years, 25 plus, Adara leadership and the team, we thought we have something to offer, and that is in terms of expertise in maternal, which is so rich, and we can't find it in the country anywhere, in most more so in the rural setting like Chiroka where we operate.
Maternal newborn health has a bit improved based on the most recent UN estimates. It is now estimated that we've moved from about 6,000 mothers dying a year to just less than 5,000. But also the newborns have also improved a bit from about 33,000 to 32,000. But we also have stillbirths. Now, the general message is, yes, there's been progress, but the progress is not fast enough.
AdaraNewborn model addresses the complex factors facing mothers and babies, addressing each point of care from the time the mother becomes pregnant, during pregnancy, and after delivery. So caring for the infant and supporting high-risk infants after going home. That is what AdaraNewborn is all about. This model aims to reduce facility-based newborn deaths and stillbirth by 50%. That is our target. In order to meet this goal, we will need to address the quality and availability of services across the continuum of care. We will work across 5 arms of critical care for mothers and babies, and we plan to work in 10 facilities in Uganda over the next decade. These 5 arms of care are antenatal arm, intrapartum arm, the inpatient arm for small and sick newborns, postnatal care for mothers and babies, and follow-up care for higher risk babies in the community, linking them to the services when needed. In each arm, we will focus interventions that will have the highest impact. So our experience at Chiwoko has shown that introducing a training program or providing equipment alone is not enough. It isn't enough to create sustainable change. So we have set ambitious goals to reach over 500,000 women and children and save thousands of newborn lives in Uganda over the next decade. Given all that we've talked about, we believe that we shall be able to save these babies.
AdaraNewborn model is very important because the AdaraNewborn model uses a regional approach, or what we call sometimes networks of care, or the hub and spoke, which means that you don't address maternal newborn care just in your facility, but you look at the entire area that is surrounding the facility that you're working in. Now, most important for Adara is that Chiwoko, we know it as a center of excellence. The center of excellence can build capacity for the health workers, but also can provide referral, and then can also go to these facilities and be able to train health workers, introduce standards, and improve care. Now, facilities that are in the region are able to refer to each other, to communicate, but also to network. And that way, you own the maternal newborn care, other than just looking at it as an issue of this facility. But most importantly, you also are able to bring political leaders, community leaders, and maybe communities on board.
We have already started expanding this model. We currently have 3 sites where this model is working. That is Kiwoko Hospital, we have Nakaseke Hospital, and Luwero Hospital. So we are extending this model. This model is really working. It is amazing.
Together with the Ugandan Ministry of Health and other partners, we're seeking to set up 2 regional hubs of maternal newborn care through AdaraNewborn. Our first hub is based in the central region of Uganda, and Kiwoko Hospital, our long-term partner, sits at the centre of that hub as our centre of excellence. So in our first regional hub, we're seeking to strengthen the quality of care across 3 districts, Nakaseke, Luwero and Nakasongola districts. Our second regional hub, we will work with the Ministry of Health to identify a really high burden site where we feel like the model can make the greatest impact.
So we went into a memorandum of understanding, that is 5 years ago, and we started working with Nakaseke General Hospital. A NICU started, which is called a SCABU, Special Baby Care Unit, with only 2 beds, and the work started continuing slowly and growing. Everybody thought newborn care in public setting, rural setting is more complicated and almost not achievable. But we said no, we have this knowledge, we have this commitment, and then this passion.
So we came in Nakaseke, and basically under our AdaraNewborn project. So under that project, we are looking at having skilled health workers. So we look at equipping health workers with our skills. We do mentorships, we do training. Not only that, we've also looked at improving the leadership and management.
We started in a small room with 3 nurses. Then later after the training, we began the NICU or the SCABU, and we started with 1 baby who was asphyxiated. Then later, they made for us a big space where now at least it is accommodating like 10 babies.
So we are continuing this partnership, and we hope all this is done to improve the life of the baby and the mother.
So since we implemented the inpatient care arm for small and sick newborns at Nakaseke, we are now starting to implement the other arms of AdaraNewborn, starting with antenatal care, intrapartum care and postnatal care. And in the next couple of years, we'll also introduce the hospital to home program at Nakaseke.
So after those 3 years, 4 years, we said, what else can we do? It's not only Nakaseke General Hospital. There are other hospitals in the district, but also there are other facilities.
As Luwero Hospital, we do have a very busy maternity section. We deliver between 350 to 400 mothers a month. A lot of those babies, maybe 15% of those babies will require special care, which previously as a hospital we didn't have. And we're ending up referring all those babies to Chiwoko, which is quite a distance from where it's around 15 kilometers from here. And for every minute you lose, for the baby it counts. When we started, of course we had to look for help, and we had experienced people in the nearby facilities, and Adara was one of the people we contacted. So initially they came and helped us with training of how to care for newborns.
We first came here last year in November to see what were the challenges actually. We realized that they had quite a number of challenges. One, they didn't have a neonatal care unit to take care of those babies. What they had was a room to care for the babies that needed some care, just to resuscitate them, and after resuscitation, they would refer them to Chiwoko.
Like you've seen, we are still at the basic level, and we need to get better than what we are doing currently. But with organizations like Adara, I think they can really show us where we are lacking, where we can improve, where government can come in as government. They need to also do their job.
You know, if you'd asked me when Adara began how many lives we would have touched, I would have said to you, you know, every life matters, every child matters, and even if it's only going to be one, that's going to be okay with me. But now here we are 25 years later, and we find with AdaraNewborn, with Adara Remote, with the Adara businesses and the work they're doing, the deep service and the knowledge sharing, we're touching hundreds of thousands of lives directly every single year, and many, many more than that through the knowledge sharing, the expertise sharing, and the sharing of mistakes.
We are at the house of Patricia, a young mother who delivered at 15 years. She's staying with her mother in this ritual house. And she has a preterm baby, which was discharged from Kiwoko Hospital 2 months ago. She has no support from the man who made her pregnant.
There was a really great day. There have been many really great days. There have been many really hard days, but there was a really great day when the first 3 triplets were born and survived in our neonate ICU, and their mum survived. And they were named Martin, Mildred and Marvin.
My name is Njamati. I am 12 years old. And my name is Ognamka Mildred, and I have 12 years old. My name is Njamati. I am 12 years old.
The triplets were born and they really needed intensive care from the expertise, and also for the family to learn how to cope up with 3 children at a go. It's quite a challenge.
I don't go to Kiwoko Hospital, but a continental, and we should have. And we went to do the other facilities. I don't know how we should have been. Chiwoko did a lot actually. Chiwoko did very much. Did a lot for these children survival.
It's an example that someone with multiple pregnancy, these babies can be taken care of and they all survive. If where they are born they have a neonatal unit, where people are equipped with knowledge, equipped with the incubators, resuscitators, and that kind of thing, and drugs to be used in the NICU. So the chances of survival can be high.
Won't be an engineer. He's going to be an engineer, and the sister is going to be a doctor.
My mom told me that she gave birth to us. To us.
How many?
3.
3.
Yes. Like the pregnancy was around 8 months, but she told me that we were prematures. Then
yes,
that was at Chiroka Hospital. Then we were put in the what?
In the machine.
In the machines. That's where we grew from. That she could come and check on us
every day.
Every day, but she was like, she was even fearing. That was Martin,
Martin was 2 times.
Over the 1.5, like he was 2 times the extent that most people were calling him a rat.
A rat?
Yeah.
Not a human being.
Not a human being. That he was too tiny, even her herself, she could fear carrying her.
But now he's grown. How old is he now?
18.
He's 18?
Yeah.
As you?
Yes.
So he's a big man?
Yeah, even he's taller than me.
Taller than you. And that's why you want to become a doctor?
Yeah.
So that you study more about human body, we grow, and then also save other lives?
Yes.
They're Adara icons. They stand at the centre and they show us the reason we do this work. The faces of these tiny little babies, when you look at them, you don't know. They're going to go on. If you give them life, if you give them a chance, they're going to go on to have great lives. They're going to go on to change their countries, their communities, their families and their world. So in that sense, for us, every single one of these babies, but Martin, Mildred and Marvin show us that story writ large. This work matters, this work is important, this work is about one child at a time.
So we must do things differently, do them better, and do them together, and do them at scale, in a very ambitious way. And even for me, this is the call to Adara, that we need to move fast, but also move systematically, and as we also learn to be able to scale up. The estimate is we need to multiply the rate at which we are progressing by 2 if we are to achieve the SDGs. So there is a lot to be done, and I hope the government and partners can invest so that these models, like the Adara model, are not just in one region of Uganda, but also are scaled up for the benefit of all mothers and newborns in the country.
So my dream is to see that we really grow this work, have more centers of excellence, but also touch more lives, more babies, more mothers, more fathers, and when they are born, but also they thrive, and we have a network of centers of excellence. And we are, end of the day, celebrating the successes in terms of reducing morbidity and mortality in our country.
My dream for the future of newborn health is when we can have the best start in life. When you have a best start in life, meaning that all newborns are wanted, they are healthy, and they also are thriving, and they grow into young adults who will actually transform Uganda, but also, as you know, because of our high population, I think also transform the world.